The really bad thing after 60 is not the number of pills in your cabinet. It is the quiet moment when a pill that once protected you starts working against a body that has changed. A pill organizer beside the kettle. A blood pressure tablet after breakfast. 2 pain pills for a sore knee. A reflux pill before bed. A supplement your neighbor recommended. Nothing feels reckless. Nothing looks urgent. That is exactly why the danger is missed. After 60, medication safety is no longer simple addition. It becomes aging math. Your kidneys filter more slowly. Your liver processes drugs differently. Your blood vessels stiffen. Your heart has less reserve. Your blood pressure swings harder. And when one pill is stacked on another, the risk is not always printed clearly on the bottle. I saw this with Robert, 76, from Calgary. Every morning, he made toast, checked the weather, and took prescriptions he had trusted for years. One weekend, knee pain pushed him to add an over-the-counter pain reliever. He did not think it mattered. By Monday, his pressure was climbing, his ankles were swollen, and his daughter was asking why a simple pill had changed that week. In the previous video, we talked about amlodipine, losartan, and lisinopril, and what seniors should ask before continuing blood pressure medicine long-term. But today, the warning is wider. Some of the most common pills after 60 raise concern not because they are always wrong, but because they become risky when kidney function, heart history, bleeding risk, food, supplements, and old prescriptions are never reviewed together. I'm Dr. Thomas Bennett. For 25 years, I have reviewed medication lists with older adults, pharmacists, families, and caregivers who were not trying to reject medicine. They were trying to understand the conversation a rushed appointment leaves unfinished. This channel helps adults over 60 understand medical research in plain language. Now, do not stop a medication because of this video. Do not throw away your prescriptions. Do not replace your doctor, pharmacist, or cardiologist with a YouTube list. This is education. It helps you ask sharper questions, request a medication review, and use medicine for the right person, at the right time, for the right goal. Here is the belief reversal. The dangerous pill is not always the strongest one. Sometimes it is the familiar one, the one you stopped questioning, the one added years ago, the one combined with another bottle, another pain reliever, or another supplement. And the data backs up why this deserves attention. A JAMA analysis of United States Emergency Department surveillance reviewed 42,585 adverse drug event cases from 58 emergency departments. Adults 65 and older accounted for 34.5% of those emergency visits, and among older adults, 43.6% were hospitalized. Another BMJ study from Denmark, led through Aarhus University Hospital, followed more than 1.3 million diclofenac starters and found a 50% higher rate of major cardiovascular events within 30 days compared with people who did not start an NSAID. So remember this: after 60, the same pill in a changed body is no longer the same decision. Today, I will give you 5 values from this 7-part review. You will learn which pill categories deserve a second conversation, why risk changes with age, which combinations demand caution, what warning signs should not be ignored, and what exact questions to ask before changing, stopping, or continuing anything. We will use the longevity lens. 3 checks. Has my body changed? Has my medication mix changed? Does this still protect my independence? Comment your age and the number of daily pills you take. Just 2 numbers. I read those comments because they show what seniors are managing at home. Do not jump ahead. Number 3 makes many people pause the first time they hear it. Number 5 is the one many never hear about until the warning sign is too loud. And number 1 changes how all 7 work together. We begin with number 7, because this is where many seniors first learn that familiar does not always mean safe. Number 7, NSAID pain pills: ibuprofen, naproxen, diclofenac, and anti-inflammatory pain relievers. This one is in millions of kitchen drawers. A senior wakes up with knee pain, back stiffness, or shoulder arthritis. They reach for ibuprofen, naproxen, diclofenac, or another anti-inflammatory pill. It feels reasonable. It feels familiar. It feels safer than asking for something stronger. And sometimes, for the right person, for a short time with medical guidance, it can be appropriate. But after 60, the hidden problem is not only stomach irritation, it is pressure, kidneys, fluid, and clotting balance. Let me show you what I mean. Margaret, 72, from Ottawa, had a sore hip after gardening. She took naproxen twice a day for a week because the bottle said it was for pain and inflammation. By the weekend, her ankles were puffy, her home blood pressure readings were higher, and she felt unusually short of breath walking upstairs. Nobody thought of the pain pill first. They thought of age. That is the mistake. NSAIDs work by blocking prostaglandins. Prostaglandins are part of inflammation, so blocking them can reduce pain. But they also help protect blood flow through the kidneys, support the stomach lining, and influence salt, water, and blood vessel tone. In an older body, when kidney reserve is lower and blood vessels are stiffer, blocking that system can raise blood pressure, worsen fluid retention, strain the kidneys, and increase cardiovascular concern in people who already have heart disease, kidney disease, hypertension, or heart failure. The data is not small. The FDA strengthened warnings that non-aspirin NSAIDs can increase heart attack and stroke risk, sometimes as early as the first weeks, with greater concern at higher doses and longer use. A BMJ nationwide Danish cohort led through Aarhus University Hospital reported that diclofenac initiators had a 50% higher rate of major adverse cardiovascular events compared with non-initiators, 20% higher than ibuprofen initiators, and 30% higher than naproxen initiators within 30 days. That does not mean one supervised occasional dose is the same as daily use, but it does mean chronic, casual use after 60 deserves a serious conversation. The safer question is not, can I tolerate this pill? The safer question is, given my age, kidney function, blood pressure, heart history, and other medications, is this anti-inflammatory still the safest pain plan for me? Ask your clinician about acetaminophen when appropriate. Topical anti-inflammatory gels, physical therapy, heat, ice, strengthening, weight-bearing support, injections when indicated, or a short supervised NSAID plan instead of an open-ended habit. Exception matters. If your doctor prescribed an NSAID for a specific inflammatory condition, post-surgical plan, or severe flare, do not stop it on your own. Ask how long, what dose, what monitoring, and what warning signs should trigger a call. Now, the next pill is different. It sounds even more responsible because many people were told for years that it protected the heart. Number 6. Daily aspirin without a clear current reason. Aspirin has a reputation that is hard to shake. Many older adults still think a baby aspirin a day keeps a heart attack away. That belief did not come from nowhere. Aspirin can be life-saving after a heart attack, stroke, stent, bypass surgery, or in specific vascular conditions when a clinician clearly recommends it. But the dangerous word is just. Just one small aspirin, just prevention, just in case. Helen, 74, from Vancouver, had taken low-dose aspirin for 9 years because a friend told her it was smart. She had no previous heart attack, no stroke, no stent. No cardiologist had recently reviewed it. Then she developed black stools and weakness. Her family thought it was fatigue. Her medication list told a different story. Here is the belief reversal. Aspirin reduces clotting. That can protect someone who has already had a clot-related event. But in a person taking it only for primary prevention, meaning no prior heart attack or stroke, the benefit may be small, while bleeding risk rises with age. After 60, the stomach lining is more vulnerable, falls are more consequential, kidney function may be lower, and many people are already taking other drugs that affect bleeding. Aspirin does not become evil. The math becomes personal. The USPSTF recommends against initiating low-dose aspirin for primary prevention of cardiovascular disease in adults 60 or older, concluding there is no net benefit in that group. In the ASPRI trial, 19,114 healthy older adults in Australia and the United States were followed for a median of 4.7 years. Aspirin did not significantly reduce cardiovascular disease, but major hemorrhage was higher at 8.6 events per 1,000 person-years versus 6.2 with placebo. The same ACC summary reported intracranial bleeding at 2.5 versus 1.7 events per 1,000 person-years, and upper gastrointestinal bleeding at 2.1 versus 1.1. So the exact question is this: am I taking aspirin for primary prevention or secondary prevention? And given my bleeding risk, age, stomach history, and other medications, should I still be on it? If the answer is secondary prevention, the conversation changes completely. Aspirin may be protecting you from another major event. Do not stop it without medical advice. If the answer is primary prevention, ask whether your blood pressure, cholesterol treatment, smoking status, diabetes control, movement, sleep, and diet may offer safer risk reduction than an automatic daily aspirin. Now we move to the combination that scares doctors more than the pill itself. Number 5. Blood thinners mixed with pain pills, aspirin, or supplements. This is where many families get caught off guard. A blood thinner may be one of the most important medications a senior takes. Warfarin, apixaban, rivaroxaban, dabigatran, and similar medications can prevent devastating strokes in people with atrial fibrillation, blood clots, mechanical valves, or other serious conditions. So I am not warning you against blood thinners. I am warning you against surprise combinations. Richard, 79, from Halifax, took apixaban for atrial fibrillation. He was careful. He used a pill organizer. He never missed a dose. Then his shoulder flared after moving boxes, and he added ibuprofen for 3 days. He also took a turmeric supplement because he heard it was natural. By Friday, he felt dizzy and noticed dark stools. His daughter brought every bottle to the pharmacy, and that is when the pattern became clear. The blood thinner was not the mistake. The unreviewed combination was: blood thinners reduce clot formation. NSAIDs can irritate the stomach lining and affect platelet function. Aspirin adds another antiplatelet effect. Some supplements may also influence bleeding risk or interact with metabolism. In an older body, a small bleed can become serious faster because blood volume reserve, kidney function, balance, and recovery capacity are not the same as they were at 50.
As we see here,
the evidence is strong enough to change behavior. A systematic review and meta-analysis found that combining warfarin with NSAIDs was associated with nearly doubled odds of gastrointestinal bleeding, with an odds ratio of 1.98. In the JAMA Emergency Department surveillance study of 42,585 adverse drug event cases across 58 U.S. emergency departments, older adults accounted for 34.5% of adverse drug event visits and had the highest hospitalization rate at 43.6%. Among adults 65 and older, anticoagulants, diabetes agents, and opioid analgesics were implicated in 59.9% of adverse drug event emergency visits, and anticoagulants alone were involved in 27.5% of visits among ages 65 to 79 and 38.8% among those 80 or older. That is why the practical question is not vague. Ask, which over-the-counter pain relievers, cold medicines, herbal supplements, vitamins, and aspirin products are safe with my blood thinner? Also, ask your pharmacist to print a medication interaction check. Bring every bottle, prescription, over-the-counter, natural, sleep aids, pain creams, cold pills, everything. And if you take more than 3 daily medications, comment review below. I want to know how many of you have never had a full medication review. And I read those comments because your questions show what older adults are really managing at home. Subscribe as well if you want these medication conversations early each day, explained calmly, without panic, and without making you feel ashamed for asking. Exception is critical. If you have atrial fibrillation, a recent clot, a mechanical valve, or a cardiologist-directed plan, your blood thinner may be protecting your life. Do not skip doses. Do not stop. Ask about safer pain options and bleeding signs. Now let's talk about a pill category that saves lives, but can still become risky when the target is no longer matched to the person. Number 4, blood pressure pills. When the target is too aggressive for the individual, high blood pressure treatment saves lives. Let us say that clearly. Treating hypertension can reduce the risk of stroke, heart failure, kidney damage, and heart attack. The problem after 70 is not that blood pressure medication is bad. The problem is when the target, dose, timing, or combination is never reviewed after the body changes. George, 81, from rural Ontario, took 3 blood pressure pills every morning. His numbers looked excellent at the clinic. But at home, he felt lightheaded after breakfast, held the counter before walking to the bathroom, and stopped going outside because he feared falling. His chart showed success. His daily life showed warning. That is the gap. Blood pressure is not only a number on paper, it is also blood flow to the brain when you stand, kidney perfusion when you are dehydrated, and balance when you walk at night. Older blood vessels are stiffer. The nervous system may respond more slowly to position changes. Diuretics, ACE inhibitors, ARBs, calcium channel blockers, beta blockers, nitrates, dehydration, and low salt intake can all interact with the standing blood pressure response. The evidence teaches nuance. In SPRINT, 9,361 adults at increased cardiovascular risk were randomized to intensive systolic blood pressure treatment below 120 versus standard treatment below 140. Intensive treatment lowered the primary cardiovascular outcome from 2.19% per year to 1.65% per year and reduced all-cause mortality, but serious adverse events such as hypotension, syncope, electrolyte abnormalities, and acute kidney injury were more frequent. Reported serious hypotension was 2.4% versus 1.4%, and acute kidney injury was 4.1% versus 2.5% in intensive versus standard treatment. European guidance also emphasizes individualized targets in older adults based on orthostatic hypotension, frailty, comorbidities, and polypharmacy. What that means in real life is simple. Lower is not always better for every senior, every day, and every body. Ask, given my age, dizziness, kidney function, falls, standing blood pressure, heart history, and home readings, is my blood pressure target still appropriate? Do not change medication because one reading is low. Keep a log. Measure sitting and standing if your clinician recommends it. Note dizziness, falls, swelling, nighttime urination, dehydration, and new weakness. Exception matters. If you have very high blood pressure, heart failure, kidney disease, previous stroke, or high cardiovascular risk, treatment may be essential. The goal is not to abandon control. The goal is control that protects both your arteries and your independence. Now, the next one surprises people because it is not only about lowering sugar anymore. Number 3, diabetes pills and the missed heart protection conversation. This one makes many seniors pause. For years, the diabetes conversation sounded like one question: is my sugar controlled? That question still matters. High glucose can damage blood vessels, nerves, kidneys, eyes, and the heart. But after 60, it may not be enough. Elaine, 70, from Toronto, had taken the same diabetes medication for 12 years. Her A1C was not terrible, as she put it, so nobody questioned the plan. But she also had kidney strain, weight gain, and a family history of heart failure. When her medication list was finally reviewed by her endocrinologist, the conversation shifted from sugar alone to heart, kidneys, weight, low blood sugar risk, and age. That is modern diabetes care. Some older diabetes pills are still useful. Some are inexpensive and appropriate. Some patients should not switch. But diabetes itself raises cardiovascular risk, and the last decade changed the evidence. For many patients with type 2 diabetes and cardiovascular or kidney risk, the best conversation is no longer only glucose. It is organ protection. SGLT2 inhibitors help the kidneys release glucose and sodium through urine, which can influence heart failure and kidney outcomes. GLP-1 receptor agonists affect glucose, appetite, weight, and vascular risk pathways. These drugs are not for everyone. They have side effects, cost issues, kidney function rules, and contraindications. But the conversation should not be missed. In EMPA-REG outcome, empagliflozin was associated with a 38% relative reduction in cardiovascular death and a 35% reduction in hospitalization for heart failure in adults with type 2 diabetes and established cardiovascular disease. In LEADER, 9,340 high-risk type 2 diabetes patients were assigned liraglutide or placebo, and reports showed a 13% lower risk of major cardiovascular events. A large Oxford-led meta-analysis of 13 major SGLT2 trials reported a 23% reduction in cardiovascular death or hospitalization for heart failure, a 37% reduction in kidney disease progression, and a 21% reduction in acute kidney injury risk. So ask your doctor or endocrinologist, is my diabetes medication still the best choice for my heart, kidneys, weight, low blood sugar risk, and age? Also ask whether you are at risk for hypoglycemia. Low sugar after 70 can mean confusion, falls, driving danger. Subscribe if you want the daily medication lessons that seniors usually only hear after something goes wrong. And if this section raises a personal question, write it in the comments with the word ask. I read those questions carefully, and I use them to guide future videos with respect, clarity, and practical value. Exception is important. Do not demand a newer medication just because it sounds modern. Some people should stay on their current plan. Some cannot take SGLT2 or GLP-1 drugs safely. The right plan depends on kidney function, heart history, weight, cost, side effects, frailty, appetite, and personal goals. Now let's move to a pill many people take for years because the original symptom disappeared so quietly. Number 2. Long-term acid reflux pills when the original reason is gone. This one sounds harmless because it often works so well. A proton pump inhibitor, or PPI, such as omeprazole, pantoprazole, esomeprazole, or lansoprazole, can calm reflux, protect the esophagus, help ulcers heal, and reduce bleeding risk in high-risk patients. For the right indication, these drugs are valuable. But the hidden problem is long-term automatic use. Dorothy, 76, from Winnipeg, started a reflux pill after a bad season of heartburn. It helped. Then 1 month became 1 year, and 1 year became 8. By the time her family doctor reviewed her medications, she could not remember why it had started. She only knew she was afraid to stop. That fear is common. The point is not that PPIs directly cause heart attacks. The cardiovascular evidence is mixed and should not be overstated. The better question is whether a daily acid-suppressing drug still has a current indication, whether it interacts with other medications, and whether long-term use is being monitored. Stomach acid helps absorb certain nutrients and acts as part of the defense system against some infections. Long-term acid suppression has been associated in observational research with kidney concerns, magnesium problems, fracture concerns, infection concerns, and medication interaction questions in selected patients. Association does not prove causation, but it does justify reassessment. A JAMA internal medicine study reported that PPI use was associated with higher risk of incident chronic kidney disease, and a BMJ summary described the increase as roughly 20 to 50% in observational cohorts. Johns Hopkins source data from the same research reported higher risk with twice-daily dosing, with an adjusted hazard ratio of 1.46 compared with once-daily dosing at 1.15. Another summary reported 10-year chronic kidney disease risk of 11.8% in baseline PPI users versus an expected 8.5% without PPI use. What does that mean in real life? Not panic. Reassessment. Ask, what is the current indication for this PPI? And if I no longer need daily use, is there a safe step-down plan? A step-down plan might include lowering dose, using it intermittently, switching to an H2 blocker, changing meal timing, reducing late-night eating, avoiding trigger foods, elevating the head of the bed, or evaluating swallowing trouble, weight loss, anemia, vomiting blood, black stools, or persistent chest discomfort. Exception is clear. Some people need long-term PPIs, severe erosive esophagitis, Barrett's esophagus, ulcer prevention with high bleeding risk, chronic NSAID use under supervision, or specialist-directed treatment. Do not stop abruptly without a clinician's plan. Now, the final category is the one many seniors do not think of as heart-related at all. Number 1. Cold, allergy, and sinus pills with hidden stimulants or blood pressure effects. This is the practical reveal. Many seniors are careful with prescriptions but casual with cold medicine. They see daytime cold and sinus. They see multi-symptom relief. They see non-drowsy. They do not always see pseudoephedrine, phenylephrine, NSAIDs, caffeine-like stimulation, or overlapping ingredients that may affect blood pressure, heart rhythm, prostate symptoms, sleep, kidneys, and other medications. Arthur, 73, from Calgary, had controlled hypertension. During a winter cold, he bought a daytime sinus pill and took it before shoveling snow. By afternoon, his heart was racing, his pressure was higher than usual, and he felt shaky. The pill was not illegal. It was not exotic. It was sitting on a pharmacy shelf. That is why it was missed. Decongestants work by tightening blood vessels in the nasal passages. That can open the nose. But blood vessels do not exist only in the nose. In sensitive people, especially those with high blood pressure, heart rhythm problems, coronary disease, prostate medication, kidney disease, or multiple prescriptions, that stimulant-like effect may matter. The numbers are nuanced. A JAMA internal medicine meta-analysis of 24 randomized placebo-controlled trials with 1,285 patients found pseudoephedrine increased systolic blood pressure by about 0.99 millimeters of mercury and heart rate by 2.83 beats per minute on average. In controlled hypertension, systolic pressure rose by about 1.2 millimeters of mercury, while higher doses and immediate release preparations produced larger effects. Another review noted that evidence is limited in medically complex older adults because many trials excluded people with active cardiovascular disease. So why make it number one if the average increase is small? Because averages hide vulnerable people. Because combination cold products can include more than one risky ingredient. Because a senior with stiff arteries, atrial fibrillation, uncontrolled pressure, prostate obstruction, kidney disease, or a blood thinner is not the same as a young, healthy trial participant. Ask your pharmacist before buying, is this cold, allergy, or sinus pill safe with my blood pressure, heart rhythm, prostate medication, blood thinner, kidney function, and current prescriptions? Safer options may include saline spray, humidified air, fluids if allowed, honey for cough if appropriate, single-ingredient acetaminophen when safe, non-sedating antihistamines without decongestants when appropriate, or products specifically chosen for people with high blood pressure. Exception matters. Severe shortness of breath, chest pain, confusion, high fever, dehydration, blue lips, worsening asthma or COPD symptoms, or symptoms that persist should not be managed with random over-the-counter pills. Call a clinician, and now you can see the pattern. The hidden danger is rarely one bottle. It is the unreviewed stack. The 7-question medication review protocol. Bring this to your doctor or pharmacist. 1. What is this medication designed to do for me today? 2. Am I taking it for primary prevention, secondary prevention, symptom control, or a temporary problem? 3. Are there heart attack, stroke, bleeding, kidney, fall, dizziness, or blood pressure risks specific to my age? 4. Does it interact with my blood thinner, aspirin, diabetes medication, blood pressure medication, reflux pill, supplement, pain reliever, or cold medicine? 5. Is there evidence for patients over 65, or am I borrowing evidence from younger adults? 6. Is there a safer alternative, lower dose, shorter duration, topical option, lifestyle step, or non-drug approach that achieves the same goal? 7. When was my full medication list last reviewed by my doctor or pharmacist? Do not ask these questions with fear. Ask them with dignity. A medication review is not disrespectful. It is responsible. It is how you protect the difference between simply taking pills and using medicine wisely. I want to be completely clear before we finish. I am not telling you these medications are bad. I am not telling you to stop taking anything. I am not replacing your doctor, pharmacist, cardiologist, endocrinologist, or personal medical care. I am telling you that after 60, every medication deserves a personalized conversation. There is a difference between medicine that simply continues because nobody questioned it and medicine that still matches the body you live in today. A pill can be right at 55 and need review at 75. A dose can be useful in winter and too strong after weight loss, dehydration, kidney decline, a fall, a new blood thinner, or a new diagnosis. A harmless-looking over-the-counter product can become risky when it is stacked on top of prescriptions. That is the whole lesson. NSAID pain pills require caution because pain relief can come with pressure, kidney, fluid, and cardiovascular trade-offs. Aspirin requires a clear reason because primary prevention and secondary prevention are not the same decision. Blood thinners require combination awareness because the stroke protection can be undermined by unreported pain pills, aspirin, and supplements. Blood pressure pills require individualized targets because protecting arteries should not mean sacrificing balance, kidney function, or independence. Diabetes medications require a modern heart and kidney conversation because sugar control is only one part of risk after 60. Reflux pills require reassessment because long-term daily use should still have a reason. Cold and sinus pills require label awareness because the heart does not know the pill came from the cold aisle. These 7 categories work as one system. They all ask the same deeper question. Does this still protect me? Or has my body changed enough that the plan needs review? Good medicine is not more pills or fewer pills. Good medicine is the right medicine for the right person at the right time for the right goal. Your body is not failing you because medication decisions became more complicated. Your body is simply older, wiser, more sensitive, and less forgiving of assumptions. That means the solution is not panic. The solution is review. Start with one action this week. Put every prescription, over-the-counter pill, supplement, pain reliever, reflux pill, aspirin bottle, and cold medicine on one table. Take a photo. Bring it to your next appointment or pharmacist visit. Ask the 7 questions. And if you know someone over 60 who uses a pill organizer, buys pain pills, takes aspirin, uses a blood thinner, or grabs cold medicine without checking the label, share this video with them. One share may prevent a dangerous combination. Subscribe if you want calm, evidence-based medication conversations for older adults, explained early and clearly, so you can ask better questions before the warning sign becomes urgent. Comment review if you want a simple medication review checklist, or tell me which category surprised you most. I read those comments because they help me understand what seniors and families are facing at home. I'm Dr. Thomas Bennett. Use medicine wisely, ask questions respectfully, and remember, the goal is not to fear your medication cabinet. The goal is to make sure every bottle in it is still serving your life, your safety, and your independence.